This is very important point to stress about.
مظبوط يا دكتور. يعني another point برضه to stress on what you said. Selecting the proper technique not only benefit for the patient in the diagnosis, but also in the cost, because sometimes you can, with the MELPA technique, which can reach about 200 euros, you can identify a disease, but searching for another with the 700 euros or 800 euros will not be inclusive for what you are looking for.
Yeah, okay. We can postpone the questions till the end of the session because we are out of the time.
Thank you.
Dr.
الأول حابة أشكر جدا وحدة البيدياتريك نيورولوجي جامعة عين شمس على الدعوة الكريمة، وشرفني وجودي معكم في المؤتمر المتميز. And now with the Professor Dr. Hoda Tamoum, she will present precision medicine in epilepsy.
Thank you again. So my presentation is related to the genetic conditions, which is precision medicine in epilepsy, which is the new term we are using, how we are precising our treatment. So nothing to disclose. Precision medicine is a personalization of treatment that ideally should target towards precise molecular pathogenesis of the disease. And epilepsy, with having a very large number of genes involved, is a good example for this. When we start evaluation a patient with epilepsy, we usually go family history, personal history, developmental disorders, additional neuropsychiatric features, physical examination, information about epilepsy, its triggers, its diurnal variation, and so forth, and brain MRI. And after that, you look for whether you look for genes or not. Genetic abnormalities can cause or influence more than 70% of epileptic syndromes, and so genetic testing should be an integral part of a pediatric workup. And this is especially so if your case is refractory or associated with developmental or cognitive disabilities. The first tier is the genomic microarray, which unfortunately is expensive in our country, and this is suitable for detecting copy number variants such as deletions or duplications, but karyotype is still the main one for detecting translocations or complex rearrangement, as Dr. Mohammed said. And if you do microarray and karyotype, you can detect 10% of infantile epilepsies and 5% of epileptic developmental encephalopathies. Because most of the cases are gene mutation, you only have this small yield if you only do karyotype and microarray. Next gene, second generation next gene sequence based gene panel can detect up to 20 and even 50% compared to genomic array, which is 5 to 10%. The cost of panels, whole exome sequence and whole genomes are rapidly falling, and that's why we are depending more and more on them. But still, the whole genome, as Mohammed and Dr. Maha said, provides a lot of data, and sometimes it is difficult to interpret. I will skip this because this is covered by Mohammed. The genes in epilepsy either affect channels and resulting in one of the channelopathies and resulting in lowering the threshold for action potential, or they can work on the neurotransmitters, tipping the balance of excitatory and inhibitory towards the excitatory side, or they can act on a presynaptic inhibition during the brain development, making the cells more hyper-excitable. So finding a treatable cause of epilepsy is the first step for diagnosis, and moreover, the discovery of genetic defect behind specific types of epilepsy can explain why some drugs are effectively very effective, or on the other hand, worsening seizures. Since a lot of metabolic errors present with epilepsy, so it goes by default that if you diagnose something like pyridoxine-dependent epilepsy or pyridoxamine 5-phosphate oxidase deficiency or GLUT1, you are more or less having a precision medicine toward seizures, because you diagnose and treat the underlying etiology. From there, we go to something like Dravet, and as mentioned many times, Dravet, the gene SCN1A, is a gene that encodes a loss of function mutation, which produces a protein that results in diminished function. So at this point, diminished or loss of function at the sodium channel, you will worsen it if you give a drug that blocks the sodium channel. like carbamazepine, phenytoin, and many other drugs, eslicarbazepine, oxcarbazepine, lamotrigine. All these drugs act on sodium channels. So when you diagnose a patient with Dravet due to SN1A gene, you should not give these drugs. This is not really a precision medicine, but yani, in the way, because you are avoiding drugs that are worsening the seizures. On the other hand, the opposite is with SCN2A and SCN8A. These are gain of function. There is excessive function at the sodium channel. So this is the opposite. When you give these drugs, you are treating your patient. Mind you, and this SCN2A, I'll go back to it again. So these drugs, the sodium channel blockings, are the main therapeutic agents because this is a gain of function mutation. Other one is the خلاص. So other one here is this KCNQ2, which can produce either benign familial neonatal seizure or early infantile epileptic encephalopathy. This is a voltage-gated potassium channel. So there is, if you can get a potassium channel opener, it will be a precision medicine. So there was a good example is this retigabine, which was the first neuronal potassium channel opener, which was considered a good, very promising drug in this gene because it was seen that it is can treat refractory epilepsy because it acts on this potassium channel. However, unfortunately, because of the serious side effects and retinitis pigmentosa and loss of vision, this drug was withdrawn in 2017. Another example is the KCNT1, which is a sodium-activated potassium channel. Here, this is a gain of function variant. So you expect something like quinidine, which is the drug that counteracts this dysfunction, that this drug, which inhibits sodium channel, can be useful in this gain of function. Quinidine, as you remember, this is an anti-malarial drug, but unfortunately, they found that the side effects of quinidine, especially the cardiac side effects, is dose limiting. When you want to reach a certain level of the drug in order to kick the effect here, but it is limited by the side effects. So not always you can get your drug, but sometimes yes. And another example here, which is promising, is the focal cortical dysplasia type 2, which is the gene is one of the mTOR genes, which is this mTOR pathway. It's mentioned many times with tuberous sclerosis. The mTOR pathway is a central regulator of cell growth, proliferation, and migration of the whole body, particularly the brain. There are two gene complexes, mTOR1 and mTOR2. Being a central regulator of growth and metabolism, mTOR responds to the presence of nutrients. So mTOR1 signals, integrates signals from multiple growth factors and nutrients and energy supply to promote cell growth when energy is sufficient, and catabolism when the body is hungry. So mTOR1 regulates cell growth and metabolism, while mTOR2 controls cell proliferation and survival. So this is the least complex diagram I could find about the mTOR. You can see here our tuberous sclerosis complex, tuberine and hamartine. So here the rehab gene, this is okay. ثواني بس ثواني أنا اتلخبطت. صح. So the rehab is this gene. This gene is an activator gene. This activates the mTOR kinase. So when we lose the inhibition, this is an inhibition. This inhibition is produced by the tuberine complex. When we have some sort of problem in this gene, like in tuberous sclerosis, you lose this inhibition. When you lose this inhibition, the mTOR kinase will be activated, unstopped. So you have hyperactivation of the mTOR kinase will result in this focal cortical dysplasias. So these genes result in focal cortical dysplasias, tuberous sclerosis 1 and 2, and here we have a precision medicine, which is everolimus and other inhibitors. There are many other examples of precision medicine, like the memantine in the genes causing NMDA are subunit, gain of function, and levetiracetam in other genes that acts on synaptic vesicles. So there are many examples. So gene discovery sets the direction for selected or engineered solutions. Finding a mutation does not necessarily mean that it is the cause of the patient's epilepsy, even if in vitro evidence that there is a change in the channel physiology. We need more evidence like segregation and so forth. If a particular epilepsy is shown to be due to a pathogenic variant in the gene encoding an ion channel, you have to know first whether it is a loss of function or gain of function mutation. And then to identify the treatment, this treatment may be a known drug like carbamazepine, or maybe a repurposed drug like I mentioned memantine or quinidine at one point. And these strategies, and sometimes you need to invent a new drugs, which sometimes take a lot of time. This is an example of a typical scenario. You have a clinical description of the case like tuberous sclerosis. You discover the gene, tuberous sclerosis 1 and 2, and then you define the disorder. And then after that, you have established a rationale for the precision medicine, like the use of rapamycin. And then you tried it and you find that it is effective in treatment. You tried it in SEGA and you find that it is effective for treatment of seizures. And then you licensed it for treatment, and then it is an acceptable line of treatment. What problems do we face? أول حاجة that the same mutation sometimes with a proven functional consequence in vitro may cause quite different clinical phenotypes or sometimes no phenotypes at all. One implication of precision medicine must be that we should seek out the mechanism that why a pathogenic variant may lead to something mild like generalized epilepsy, febrile seizure plus in one individual, and something very severe like Dravet even in his relative. Maybe it is related to mosaicism, maybe it is related to other genetic variants taking in consideration, because if you know that genes of epilepsy interact with other gene networks that are involved in other conditions like related to cognitive delay. So these genes all interact and have different effects on clinical picture. Another problem is that the causative role of gene mutation may be challenging because some mutation can cause variable phenotypes. Like, as I mentioned many times, SCN1A, which is very well known for Dravet, it can cause many other conditions and so forth. Every gene can have a multiple of phenotypes. And the reverse. إحنا رحنا فين؟ أنا ماشية غلط؟ لا أنا بطلع. Sorry. And then on the other hand, a disease like Dravet, which is, yes, SCN1A is positive in 90%. You have many other genes can cause Dravet. Many genes can cause early infantile migrating focal seizures. So this problem has two phases and both makes it difficult. Another problem, is it a gain of function or loss of function? So remember this gene, SCN2A, strangely, this gene can cause gain of function or loss of function. So you have your gene and you are not sure whether you should give a sodium channel blocker or you should avoid a sodium channel blocker. And this is a problem I faced when I have one of my patients diagnosed with this one. So even I contacted Centogene and I asked them, is this a gain of function or loss of function mutation? So they referred me to this paper, which didn't help much. They said, Wolf hypothesized that the same gene mutation can cause gain of function variants, which results in earlier seizure and good response to sodium channel blockers, and loss of function, which results if it occurs in later seizure onset. So if you have your patient with early onset, think this is most likely a gain of function. When you have your seizure later, this most likely a loss of function. But again, larger phenotypic variability, high variable response to medication, even in a patient with a similar phenotype or same variant. So it's never easy. Another problem, blended phenotype, which is the first time I hear this term when I was preparing this one. The ability of something like a whole exome to give me multiple genes have resulting in this term, blended phenotype. What do we mean by blended phenotype? The patient may have whose disorder might be explained by more than one gene. I'll tell you this very nice example. This is a family of two sisters. The two sisters both have brain calcification and both have seizures. Okay. Both sisters and their father have a variant in SCL20A2 gene, which is associated with idiopathic basal ganglia. Remember that both children have basal ganglia calcification and seizure. Their father, who harbors the same heterozygous mutation, have no seizures. Now, their mother, both the SIBs and their mother have a gene CHRNB2, which is associated with autosomal dominant frontal lobe epilepsy. Mom, heterozygous, same gene, completely asymptomatic, and the children are having seizures. So why do they both have seizures when the parents who harbor one gene and the other gene do not? So the conclusion was that neither the father, who only harbored the first gene, or the mother had seizure. So both variants together might sufficiently lower the seizure threshold to give rise to epilepsy. So this is the term of blended phenotype. When precision medicine is successful, there should be direct mechanistic evidence that it has achieved what it was intended to achieve. And equally, when there is failure, there should be explanation. There is a problem that there is a bias in literature towards successful or promising or very nice results and not publishing the failure results. An example is the use of quinidine in epilepsies due to gain of function in KCNT1. This is an example where initial success and bias against publication of negative outcome was in the beginning, and all literature was very enthusiastic about the use of it, and later on came the results that it is not beneficial anymore. That's not beneficial. So even the journals are biased towards successful rather than failure results. Coming to your question, Maha, this study looked into the multiple gene next generation sequencing panel with simultaneous sequence and exonic copy number variants on 183 epilepsy-related genes in 9,769 individuals. They found that molecular genetic tests provided a diagnosis in about 15 to 25% of individuals with epilepsy, and more than half of these diagnoses were in children younger than 5 years. Notably, the testing had possible precision medicine in 1/3 of them. So you diagnose between 15 and 25, you can help in 1/3 of these individuals, and only 30 genes provided 80% of the molecular diagnosis. So you have 80 genes, you should focus on them. 30 genes, I mean, sorry. Still a long way for reaching. There is gene therapy, and there is a lot of genes that are under investigation, but still nothing concrete. And allow me to share just two cases with you. This is a male boy of unrelated parents who present at the age of 11 days with attacks of apnea and cyanosis. Later, it changed to focal limb jerks that occurred on both sides and occasionally repetitive a day. Father had seizures in the neonatal period that remitted spontaneously. High-resolution MRI, basic metabolic workup, did not get anything. B6 failed, and even levotiroster. So we asked for whole exome, and it came to show heterozygous variant of uncertain significance in the missense mutation in KCNQ2 gene. Remember, this gene has a potential efficacy for sodium channel blocker. So we started him on carbamazepine. Seizure remitted, development is very normal. This is another one. This is another boy of unrelated parents. He had seizures which started at the day 2. The boy developed multiple seizure types all through his history, including focal, generalized tonic, generalized clonic, and infantile spasm. Seizure remitted by 12 months after several anti-epileptic drugs, including phenobarb, valproate, topiramate, SCH, and B6. And at one point, it was seen that he responded very rapidly to phenytoin during seizure breakthrough. He had global delay, but mainly severe cognitive delay, autistic feature, and is nonverbal and incontinent by the age of 5.5. His elder sib had seizures since the second day of life that remitted by 14 months, and the boy is developing just barely below peers. Mom had seizures that remitted in infancy. So we have a variable clinical picture in the family of very bad developmental delay and seizure that were very difficult, and child barely developing normally, and mom with just seizure that remitted by itself. So again, high resolution MRI, metabolic profile by 10 days, CSF, glucose, glycemia, very long chains, self-sustain, all negative. So we asked for whole exome sequence, and it showed heterozygous likely pathogenic variant mutation in KC and QT gene, the one gene that we saw in the first patient, yes? So, and another heterozygous variant in our uncertain significant in DPP6 gene. This is the gene, remember, this is the same gene with the sodium channel, which may explain why he responded at one point very well to phenytoin. So, أنا مش عارفة أرجع. أنا برجع من تحت. سوري. طب رجعه لي تاني. معلش آخر اليوم. انتوا طبعا عايزين السلايد الأخرانية. So the question here, why did this boy presented this dramatically, and why did his family presented this mildly? In my opinion, because you know that we cannot afford to do trial, so we are trying just to explain with what we have. We are just having this patient. My explanation is one of two things. Either this is an example of variable phenotype of the same mutation, because this gene can present with benign familial neonatal or developmental epileptic encephalopathy type 7, as I mentioned before. So either it is a variable gene presentation, or another thing is that this is maybe a blended phenotype, because this child has another gene, which is the autosomal dominant intellectual developmental disorder type 33. Maybe he has this one, and the other family had only the KC and QT. So maybe this is an example of developmental, of blended phenotype. These are my explanation until we can afford to do the trial. So still it is a long way. It is a new era. Hence, initiating curated registries of epilepsy patients, increasing number of multi-center randomized controlled trials are needed. Multi-center collaboration is needed to bridge the gap between epilepsy, patient epilepsy clinician and researchers. And this governs the way for epilepsy genetics into clinics. Thank you.
شكرا جزيلا أستاذة الدكتورة هدى طموم على المحاضرة الرائعة. يعني أنا قلت إن أنا هخلي كومنتس في الأسئلة في الآخر، بس فعلا أنا عايزة جاست كومنت صغير بس قد كده عشان بس الحاجات تبقى ورا بعضها. في نقطتين بس. اولا هي الدكتوره هدى جاوبت على سؤال نهى ثروت اللي هي حطته اللي كنا هنرد عليه السنه الجايه، فهي جاوبته في المحاضره ان هي مش بالضروره ان هو طالما ان هو شانل تايب 1 صوديوم شانل تايب 1 ان هو يبقى درافي، ده هو ممكن يبقى حاجه ثانيه او يعني ده سبيكترم. النقطه الثانيه اللي هي قضيه اللي هي البلندد جينوتايب. هنا في البيبر اللي كويس جدا انت حطيتي البيبر. لازم عشان اقول يا جماعه جين لازم اشوفه في البيرنس، يعني انا اعمل البيدجري واشوفه البيرنس. فاحنا للاسف الشديد بناخد البروباند وما بناخدش البيرنس. عشان كده برضو الحاله الاخرانيه احنا مش مضطرين ندفع كتير، احنا مضطرين بس هنعمل التو جينز دول في الفاميلي اللي هي الام والاب والولد، بس التو جينز دول. ولازم نفورس محمد عماره مشي، لازم نفورس اللاب الجينيتك لابس ان هم يعملوا لنا الترايو دول مجانا، لان هو ده المفروض ان هو البراكتس في كل العالم، ان هو المفروض ان هو او فيري شيب، علشان احنا مش بنعيد التست من اوله لاخره، احنا جاست بنشوف التو جينز دي. فذيس از ماي كومنت. في برضه نقطه ساعات بتطلع اللي هي الفاريانت اوف uncertain significance، ودي بتوقعنا في مشكله كبيره، فعشان كده بتتحل برضه بان احنا بنعمل التريو. انا بشفت بقى للنكست. شكرا جزيلا. Next speaker will be دكتورة عبير سلامة، lecturer of neuropediatrics كفر الشيخ يونيفرسيتي. احنا بس عملنا تشينج في السكيدجول علشان دكتورة عبير عندها سفر. دكتورة عبير will talk about a case of spastic diplegia of non-progressive course severe under the age.
يبقى Zoom.